also like to note that I'm being joined by my colleagues, Jason Kleinman, Keith Krasinski, and Len Marquez, and Gail Lee, who may participate in the Q&A portion of the session. I do want to note that this briefing is being recorded and that we will send a copy of the recording along with the slides to all of the participants that have registered. Today's session is really going to highlight the important role that I think all of you know about already, the important role that telehealth played during the pandemic, specifically by our America's teaching hospitals and medical schools, and the opportunities and the importance of maintaining those gains that we have achieved through COVID as we continue to hopefully start moving back into a post-COVID world, and the importance of what telehealth can do throughout our regular healthcare system moving forward. Keith, if you can move to the second slide. I think most of you know about the AAMC, that we represent all of the medical schools as well as the major teaching hospitals, and as well as academic societies. And as a result, we work with and have the privilege to serve and lead faculty, physicians, over 179,000, as well as the large major teaching hospitals in the country, and the medical school students and residents. And all of those people and entities played such a critical role during the pandemic, but they also, as part of that role, played a critical role in the use of telehealth going forward. The AAMC in the next slide is not surprisingly, because of who we are, focuses on transferring and looking at medical education, healthcare, research, and community collaborations. For those of you who have been following this, so many of our health staff, we are so appreciative to Congress for the waivers and the telehealth policies that were included in the various pieces of legislation throughout the year. You can see them here on this slide. I won't go into them with detail, but we know a lot of work went into those on the part of Congress, and we're very appreciative of that. And we do want to talk about why it's so important to keep those going forward in the future. I'm very excited that we're able to, that I'm being joined by several of our prestigious colleagues. My colleague, Janis Orlowski, Dr. Janis Orlowski, who's our Chief Healthcare Officer at the AAMC, as well as two panelists of whom you saw their bios looping as you were joining the teleconference. But they are Dr. Karen Rheuban, who's Professor of Pediatrics and Director of Telemedicine at the University of Virginia Healthcare System, and Dr. Darren Malinoski, Professor of Surgery and the Chief Clinical Transformation Officer of the Oregon Health and Sciences University. There's going to be a Q&A period following the presentations, and we hope that you'll use the Q&A button at the bottom of your screen to be able to submit any questions that I will then ask our panelists. And with that, I'm going to turn it over to my colleague, Dr. Janis Orlowski, to get us started. Janis?
Thanks very much, Karen, and good morning to everyone. Next slide, please. I'd just like to set the stage for information about telehealth. This is information that comes to us pre-COVID, and it talked about teaching hospitals' adoption of telehealth. And what we saw was that 82% of large and 68% of minor teaching hospitals were already preparing to use telehealth. They were not using it, but they were preparing to use telehealth as a way to practice medicine. Next slide, please. This is a little bit of a busy slide, but I love it. It's data that comes from about 90 plus academic faculty practices. So these faculty practices have on average a little less than 1,000 physicians in them, and it's great information to follow. So the colors tell you about the kind of insurance. So blue is commercial, this yellowish orange is Medicare, purple is Medicaid, and the green is other. And what this slide shows you is the dark, if we look on the left, the dark lines, the solid lines tell you face-to-face ambulatory encounters, and the dotted lines here on the bottom tell you about telehealth encounters. And essentially what this slide shows you, and two things that I want to point out, is that as we all know, in March, the number of face-to-face encounters dropped dramatically because of the pandemic. But what we saw was an amazing increase within 2 weeks of the number of telehealth visits. And so essentially, we responded immediately to the need to provide health, not just to those who came to the hospital because of COVID, but we needed to continue to provide health to those who had other medical conditions. And I think that the second thing that I want to point out is that even though the telehealth regulations continue, what you saw is that you didn't see a continued expansion of telehealth, that you saw that some people are going to be seen face-to-face, and then other people are going to be seen by telehealth. And I think you see what is a natural sorting. So the concern that there's going to be overuse of telehealth, I think this slide says, not so much. We have the ability, we have the regulations in place right now. And people said, these are the individuals that need to have face-to-face encounters. And this is the level of telehealth that is practiced right now in the United States. Next slide, please. This is an example. This is from April of 2020, and it was just a snapshot. On the right-hand side, the darker blue tells us the number of telehealth visits, and the gray is the number of face-to-face visits. And as you would expect, there are certain specialties, dermatology, family medicine, certainly behavioral health, and others that lend themselves to telehealth. And then there's others where telehealth is not practiced in those specialties. Next slide, please. One of the things that I wanted to mention, you're going to hear about this, but I continue to practice as a nephrologist. And I want to tell you that audio-only services were very critical. And I think that I can say two things. One is I was able to practice medicine by an audio-only service. And the second thing that I would tell you is that I saw that individuals who did not have access to broadband, who were older or could not afford smartphones, were the individuals who I needed to be in contact with, and we could only do it through audio-only services. Certainly, I saw other people through telehealth and face-to-face, but I want to stress, sort of in my experience, how important audio-only services were. Next slide, please. The interesting thing is that the AAMC started before the pandemic to take a look at what we call competencies of education. So this is what we use to talk to medical schools, to residency programs, and to faculty in regards to requirements for education. So prior to the pandemic, we were taking a look and had a committee together taking a look at telehealth competencies, and they were organized by the following 6 domains. And what we published then were requirements. So you're at the end of medical school, what should you be competent to do as a graduating medical student? At the end of residency, what should you be able to do to be competent at the end of residency? And then for midterm faculty. And so these competencies are used for many other areas in medicine. And I think that it was very prescient that we were working on the telehealth competencies prior to the COVID, and they were actually published during the pandemic. Next slide, please. And so, as I mentioned, we are taking a look at the future of telehealth in multiple discussions with CEOs and directors of practice plans and others. What we see right now is that telehealth is about 10 to 20% of the care delivery, and that we can envision a future where this is an important component and likely to be a larger percentage of healthcare delivery. Next slide, please. And with that, what I'd like to do is turn this over to Dr. Karen Rheuban. Karen?
Thank you so much, Dr. Orlowski. I appreciate it. And welcome to all who are joining us. And I want to express my appreciation as well to members of the administration and to Congress for all the changes that have happened during the public health emergency and hopefully going forward as well. So it's a real privilege to be here today. Next slide, please. Just a brief overview of the UVA telemedicine program history prior to COVID-19 that sets the stage for a demonstration of the changes that happened following the waivers implemented and CARES Act funding as well that advanced all that we are doing to serve patients across the Commonwealth of Virginia. So we have a 25-year telemedicine program in the Commonwealth of Virginia. We are a HRSA-funded telehealth resource center and serve 8 states and the District of Columbia, providing technical assistance. Our program prior to COVID-19 was focused primarily on synchronous video-based telehealth services, primarily specialty and orientation, with patients being at healthcare facilities. We also offered asynchronous services such as screening for diabetic retinopathy, some teledermatology services as well. Speaking of prescient, we had a special pathogen telemedicine program in our 5-bed medical ICU, which we call ISACOMs. We are one of the state's 2 Ebola hospitals, special pathogen hospitals. And so we had already established the use of telehealth as virtual personal protective equipment. We also had a multi-year remote patient monitoring program, managing patients with chronic illness, reducing hospital readmissions, and dealing with certain complex conditions as well. Thanks to work with the AAMC, we offered provider-to-provider e-consults, and then offered provider and patient educational programs such as Project Echo, a website, a learning portal that we have offering continuing education credit called Telehealth Village, and we offer diabetes patient education as well. And of course, as an academic medical center, telehealth is part of our research portfolio as well. Next slide, please. Our network prior to COVID-19 included telemedicine partners across the Commonwealth of Virginia, community hospitals, including critical access hospitals. We had telestroke sites that are outlined as red stars, federally qualified health centers, free clinics, community service boards, which are the outpatient facilities of our Department of Behavioral Health, medical practice sites, Virginia Department of Health sites, correctional facilities, PACE programs, dialysis facilities, and some connections with skilled nursing, long-term care, and rehabilitation facilities, and a number of schools in rural regions of the Commonwealth of Virginia. Next, please. There were, as many of you know, significant pre-COVID-19 Medicare policy challenges that we refer to as the 1834M restrictions in the Social Security Act. And some of those included the restrictions both at originating site where the patient is located and distant site where the provider is located. So we were limited as to the type of facility at which the patient could be located, and the home was not considered an eligible originating site. There was a rural requirement for us to be able to be paid for services provided to Medicare beneficiaries, with the exception of some changes that happened prior to COVID-19, such as telestroke, home dialysis, and certain mental health services. There were limited eligible distance site providers. Not all Medicare providers would be eligible to be reimbursed for services provided through telemedicine. There were limited covered CPT codes. There was no coverage of audio-only services, which was worsening disparities that many patients face, in particular because of low bandwidth in certain communities, as well as language barriers as well. Federally qualified health centers were ineligible to serve as distance site providers, and there were significant malalignments with state coverage policies. And of course, as we know, limited adoption of alternative payment models. Next, please. So we were very heartened by the Medicare waivers, and that really transformed our ability to provide services to our patients. And again, remember, our program was primarily a specialty telemedicine service. So we were able to backfill ambulatory visits with home-based synchronous video services, assuming the patient had sufficient bandwidth at their home, and experienced an 11-fold increase in telemedicine services in the first 4 months of the public health emergency. We expanded our ISACOM special pathogen program to more than 100 rooms at UVA Health, including our Department of Emergency Medicine. We rapidly scaled to provide COVID-19 testing and consultative support in congregate care facilities such as long-term care, skilled nursing, and correctional settings where the prevalence of COVID-19 was very significant. In fact, we received an SOS from one long-term care facility where 95% of the patients and all but one of the providers were infected with COVID-19. And that day we deployed telemedicine equipment to that site and provided point prevalence testing and support for the healthcare system there. We launched a virtual urgent care program to reduce ED visits and exposure. We expanded our remote patient monitoring program to include COVID-19 patients with video check-ins by nurse practitioners that would enable us to escalate care as appropriate or to follow patients after discharge from the hospital. And then we also expanded our e-consult program. Next, please. As you'll see, the specialty distribution of our video visits following COVID-19 changed from being primarily specialty to primary care as well, with a large number of encounters supported by Department of Medicine, by pediatrics, psychiatry, which was always our busiest service, our clinical practice group, but neurology scaled, family medicine scaled, and all the other specialties participated as well, but not to the degree that primary care telemedicine scaled rapidly. Next, please. I'd like to show you the map. We use a Tableau database to track our encounters, which also looks at zip codes of our patients. And you can see in February of 2020, our specialty telemedicine visits primarily showed that we served patients in the western half of Virginia, which was our traditional referral area for specialty services. But notice what happened by May of 2020, 3 months later, we were serving patients all across the Commonwealth of Virginia through our telemedicine program. Next, please. How about patient and provider satisfaction? Patients love telemedicine. The Press Ganey reports of telemedicine quality are superb. Patients love it. Why not? If you don't have to pick up and drive a long distance to see your provider. So for us, our data, even when we had situations where patients didn't have sufficient bandwidth, their willingness to recommend UVA, in-person services 94.2 versus telemedicine care 91.5. And we hope to change that as we are implementing additional new changes in our telemedicine program as well. For our own providers, they are still willing to maintain or even increase telemedicine visits over the next year, 79%. We, again, as I said, we have implemented new platforms, new services, and have done some additional changes, which I'll refer to. But one of the highlights of our telemedicine program is that we have saved patients more than 32 million miles of driving within the Commonwealth of Virginia. And that's a lot of carbon credit too. So next slide, please. Okay, virtual care transformations require significant health system and or provider investments. I cannot state that enough, and therefore payment parity for telemedicine encounters is important for program sustainability. Systems have been investing in HIPAA compliant, EMR integrated solutions, and in our case with multi-party video to support resident supervision and medical student engagement. We've had to procure more devices, webcams and headsets for our providers, peripheral devices for our patients. And we've had to scale up bandwidth. And in fact, for our remote patient monitoring program, we're actually providing bandwidth to patients embedded within tablets that we are providing for remote patient monitoring for patients with chronic illness. We've had to develop workflows, provider training manuals. We have scheduling staff resources that we have to expend, whether the visits are virtual or whether they are in person, and rooming resources. And we have just outsourced for patient support services because for me as a provider, my colleagues as providers, we want to be able to do what we're supposed to do, which is taking care of patients, but we don't need to be helping our patients connect. So health systems have had to invest in mechanisms by which they can support our patients who are receiving telemedicine services. Next, please. I had the privilege of serving as the board chair of Virginia MEDICAID, and this is data that has come to me from my colleague, Dr. Chetan Bacciareddy. Some of you may have heard Dr. Bacciareddy speak. So our Medicaid data about utilization is quite significant. Telehealth has increased 15 times during COVID-19, and between July 2019 and December 2020, Dr. Bacciareddy has presented this data showing that Virginia Medicaid has supported more than almost 1 million telehealth visits. And if you look at the numbers, of course, pre-COVID-19, it was relatively low. background music, in fact, but then Medicaid providers supported large numbers of telehealth encounters and continue to do so today. Next, please. He has also demonstrated that telehealth has been a force for equity with greater utilization by African-American Medicaid beneficiaries than prior to COVID-19 and other underrepresented minorities as well. And I will say Dr. Bacciaretti has tracked his own clinic patient visits during COVID-19 and reported a reduction from 27% of missed appointments to 3%, a significant reduction in missed appointments. And recent data published in the Telemedicine Journal has demonstrated the same as well. Next, please. This is one of the points that I think is really important for everyone to realize. Virginia Medicaid, when we looked at program integrity, has demonstrated that costs have not gone up with the expansion of telehealth. And in fact, the telehealth visits have largely been substitutive. So costs have not gone up, and that is really important for consideration. And they have mechanisms in place where they do track program integrity and have not demonstrated any significant fraud and abuse. Next, please. So in summary, the telehealth waivers have enabled a significant scaling of telehealth services. The shift also now includes primary care services. Medicaid data has shown that telehealth services are largely substitutive and not additive. Telehealth has resulted in a reduction in missed appointments. Telehealth can be a force for equity. Audio-only services are important, particularly in the context of an existing provider-patient relationship. Health system and provider investments in telehealth are quite significant. Provider work effort is not dissimilar to in-person work effort, and patient satisfaction is high. And we like to say telehealth care is really healthcare. So with that, it's a pleasure to introduce my colleague, Dr. Darren Malinoski, Chief Clinical Transformation Officer at Oregon Health and Sciences University. Thank you.
Thank you for the handoff, Dr. Rheuban, and for the AAMC for the opportunity to share in this briefing, and for all of you who are attending as well. I think what you'll hear is that OHSU has a pretty similar experience as Virginia, and I hope to share a little more background on some of our motives and some of the opportunities that we've realized through telehealth. And again, much appreciation for the waivers during COVID, and another endorsement for the importance for those to continue. And the title of this whole briefing is about how teaching hospitals continue to expand access to care. And I think that is the primary driver of this for us. Dr. Orlowski mentioned that there's concern over fraud or abuse or overuse. Dr. Rheuban also mentioned that there hasn't been a lot of evidence of that. And if you think about the motive behind it, it really is expanding access to care. Our mission is to serve our patients. And when you're weighing the pros and cons of this, I think you'll see that the pros far outweigh the downsides, and expanding access to care is really our goal. So the picture you see on the top here is our main hospital campus up on the hill in Portland, and you'll see 2 tram cars leading down from that. And I love this slide because it's a perfect metaphor for OHSU. We're a tertiary quaternary site that serves the state of Oregon, and we have access challenges. We're up on a hill. It's hard to get to. Parking is limited. We expanded our campus several blocks away at a lower elevation, and this shows the extent to which we will go to innovate to improve access to care. We built a tram from one campus down to the other to connect the two. So it's a perfect metaphor for the challenges to access, and yet how far we'll go to innovate to try and make that a reality. I also want to call out Mark Lovegren, my partner in crime with Digital Health at OHSU, who's helped prepare these slides and available for questions if needed. And many other people on our team are here as well. On the next slide, you'll see the other view from that tram, looking out towards the campus down by the river, and then out towards Mount Hood to the east. And we really take to heart our mission, which is to serve Oregonians and beyond. We are a public corporation who views its role to provide care to those who need it, and we'll innovate as much as we can along the way. And this really shows the extent to which we go and how we view the state. So on the next slide, you'll see a map of Oregon that shows the different telemedicine activities and statewide collaborations we've had. And this slide actually predates COVID as well. Similar to Virginia, we had many programs in place, but at a much smaller scale before COVID. We have educational collaborations, and partnership really is the nature of how we provide the service to the state. And we even had some telemedicine outreach clinics in different locations that you can see throughout the state. And on the next slide, you'll see those telemedicine outreach clinics more specifically. As was mentioned, we also have telestroke coverage, some neonatal and pediatric intensive care unit work. Miles Ellenby is one of our pediatric intensivists, and he and Mark Lukren actually began our telehealth program about 15 years ago in response to local hospitals, rural hospitals who wanted to keep patients in their facilities but needed some backup support to do so. And with that in place, we've reached thousands of patients, and similar to Virginia, saved millions of miles in driving, but also allowed patients to stay at home or stay in their home neighborhoods with their providers and family close by, and it really helps us serve the state to maintain capacity and increase resources throughout. On the next slide, you'll see that we began to pivot from a focus on the outreach clinics and hospital connections in terms of a reactive approach. Someone's asking for help and we provide that peer-to-peer support, to then having patient-centered options as well. And again, prior to COVID and due to the response of the local state large payers, so the public employee boards wanted to have telehealth options. And they asked OHSU to create a virtual visit urgent care program as part of that insurance plan. And it was recognized, this was about 5 years ago, that patients wanted more healthcare on demand and in the palm of their hands and more accessibility. So we did have a virtual visit program prior to COVID, but I will say that our volumes were in the 10 to 15 patient a day range, much, much smaller than obviously we realized during COVID. But we began to build a portfolio of other tools besides those outreach clinics and hospital-to-hospital connections. On the next slide, you'll see our digital toolbox. And we had elements of these, all of these, prior to COVID, but again, in much smaller scale. So we bucket them into who's involved in the digital health exchange. Is it provider to patient, our classic sense, or provider to provider? And is it live or synchronous, like a phone call or a video visit, that replacing an in-person visit? Or is it asynchronous or store and forward? And there's patient portals like MyChart, e-visits, which again are asynchronous, patient enters data, provider responds when they can, and or ongoing remote patient monitoring. And that can be a hybrid crossing over from inpatient to outpatient. On the provider to provider side, obviously phone calls happen and emails happen and live telemedicine consults happen, but you can also do an asynchronous exchange called an e-consult. And similar to Virginia, we had this in place prior to COVID, and it was actually our largest volume tool prior to COVID were our e-consults. On the next slide, you'll see that back in 2019, OHSU became OHSU Health, and a health system was formed with several hospitals in the Portland metro area. And we had a strategic planning initiative to chart our path forward, a 5 or 6 year vision, OHSU 2025. And with great crowdsourcing and involvement of thousands of employees, we came up with some initiatives to take us forward for the next 5 years. And you'll see at the bottom line there, the Office of Digital Health was one of those initiatives to take these tools we developed and try to expand those at scale. And our goal by 2025 was to get to 20% of our ambulatory visits being digital. It's really fascinating to see how these numbers are leveling out at a nationwide level, because we happen to pick perhaps a good target. This was based on some safety net data in California and information from the Kaiser Foundation on what percentage of care they provided digitally. And you realize that they are a high performer for a few reasons. They're a payer, and they're a unified health system, and they have their own EMR. So when you have that all wrapped up, you can decide what the right care is. And when you do that, you realize that over 20% of care can be provided digitally. And so with all this in mind and having a health system, we asked ourselves, where do we go next? Do we expand our campus? And the next slide, you'll see what we came up with. We decided that in actuality, the home is our next campus. And this was again in 2019 prior to COVID. So we had a roadmap in place to try to expand digital services to patients to meet them where they were. The home is an infinite campus. And if we can reach patients there, we can provide better service to all Oregonians and beyond. So on the next slide, you'll see what happened during COVID. So we had this roadmap in place, and we had a 2025 goal to get to about 20,000 digital visits a month, which would be 20% of our volume. And we wanted to get there again over 5 to 6 years. And on the far left in 2019, you see where our numbers were. We were doing about 2,000 to 3,000 visits a month, and we were at about 1%. And we wanted to double that each year to get to 20%. And the different types of tools that make up those numbers are listed in the table above. And you can see we rapidly expanded over the course of 2 months to get way past our 2025 goal. And part of that was the burning platform in need of COVID, but also the unmet demand that was already there. So we rapidly scaled at first telephone visits in the dark blue because that was easier to operationalize. And then we quickly onboarded as many providers as we could for video visits within our EMR, which is no small feat. And then over time, as more providers and patients became digitally competent and able to do video visits, that surpassed our telephone visits. But as you can see, they've really continued, and there's been some slow downtrends as there's been more in-person care and more vaccinations and more comfort with in-person care. But there's still this underlying demand that patients and providers both feel is appropriate. On the next slide, you'll see that we take a percentage of those visits, not just the raw number. But here the colors are a little different, but in blue would be in-person visits, in red would be phone visits, and in gray would be telephone visits, and then the telemedicine are those outreach clinics. And you can see the percentage of care on the far right, and you can see that digital visits prior to COVID were obviously 1% or less of all of our ambulatory care. And then it went to exceeding 70% at some cases, or rather touched 70% in April of the pandemic. And you can see that again, leveled out over time, and we wound up leveling out at about 30%, 25 to 30% of ambulatory care is still provided digitally. And you see that alteration in September on the right-hand side, and that was actually when we had some wildfires in Oregon. And because of pollution and unsafe conditions traveling and coming to work at times, we had more visits that had to become digital. And so what this tells you is once we built the infrastructure and the know-how, when crises occur, we can pivot on a dime and transition visits to digital when needed. And this becomes an ongoing resource into the future. On the next slide, you'll see that we actually increased capacity. So pre-COVID, that dark line there shows the number of ambulatory visits we would do in a given week. So when you add digital visits on top of that, we've increased our capacity by about 10+%. So you can add more visits without building more buildings, which again suggests it might lead one to think that that's cheaper care. But as Dr. Rheuban described, it's not, because there's such infrastructure needed to provide services for digital health. It's just complementary services, but we were able to expand access with providers just doing more visits in the same week. On the next slide, you'll see that this is the level of effort that's required to do that type of expansion. So on the left-hand side, you'll see a number of EPIC departments, which are really clinics. An academic department of dermatology, let's say, could have 5 different clinics. And the number of providers below that. So over the course of 3 weeks, we added about 1,000 providers to be video enabled. And these are the team members on the right-hand side that are required to really pull this off. And then the ongoing technology support, the workflows, the changes with EMR upgrades, with new regulatory changes, improving the experience over time, because when you rapidly expand, you then need to optimize for years to come to really make the workflow optimal and really reach patients and providers who have been the low adopters and unable to come forward. So massive team effort to pull this off. And these team members continue to stay engaged in digital health moving forward. On the next slide, you'll see the reach of these efforts. So this is the home address of patients at the time, not necessarily where they were at the visit, because that wasn't collected at the data point the same way, but using the EMR address for the patient, you can see we reached patients in virtually all states, no pun intended. And by tracking the waivers that were allowed, we tried to create an infrastructure that let providers know when they could and couldn't see patients, established versus new, with without a license, whether you had to register or not. There were a lot of permutations to do with this. And moving forward, it'll be crucial that we're able to provide ongoing care to these patients who now have an established relationship with us. And so I think as we think about interstate licensure, I know it's a complicated topic, but continuity of care is an area where I think we could find some common ground. And I would refer people to Washington State Commission, who already before COVID had a policy in place allowing continuity of care for border patients or traveling patients or people who travel for a procedure, because that established provider has the best ability to take care of that patient. And again, it's not about grabbing a market or making a financial play. It's about providing the right care for patients. And we need to be able to keep doing that after the pandemic ends. On the next slide, you'll see how we provided value for rural patients, both within Oregon and Washington. And this is the time that was saved with a virtual visit compared to an in-person visit. So this is patient-attested survey data. How much time did they take off for their virtual visit? and how much time would they need to take off for a comparable in-person visit. So green would be no time off, and then the colors, red being the greatest amount of time, show that on the right-hand side for in-person visits, clearly patients have to take off more time, especially in a rural state with long travel times, and the single academic coronary site as a resource for all Oregonians, and then people in neighboring states around the borders as well. So clearly value here, both in time saved, and as Dr. Rheuban mentioned, millions of miles saved in driving. So we can clearly take that up to a climate issue as well. On the next slide, you'll see a specific example of how this really affected a rural patient. So we have been trying to do external e-consults, patients not already on our EMR, with providers not on our system, and it's a complicated task. Technologically probably simple, but regulatory-wise and billing-wise complicated. But we've worked with a pilot program and worked with rural providers who reached out to us over time for help with access to care. And with a small attachment on a smartphone called a dermatoscope, a rural primary care provider was able to take a photo of a patient's lesion and ask, is this concern for melanoma or something vascular, in an 82-year-old male? There was no local access to dermatology for several weeks. OHSU was several weeks booked out as well, and this patient was several hours away. So this rural provider was able to send us this external e-consult with this photo, and Dr. Keller, our dermatologist, recognized immediately a high concern for melanoma, and he picked up the phone, called the local dermatologist in the rural area, and said, you need to get this patient in for an immediate biopsy. And he facilitated that care for the rural provider by recognizing the need by seeing the photo. Digital health helps patients and improves care. And again, it can even help connect patients to rural providers, and we can help facilitate that. And I have to say that Dr. Leachman, our chair of dermatology, has been a huge early adopter of digital health, even developed an app to map moles, a mole mapper on the war against melanoma, to again help people recognize their concerns and reach as many patients as we can in the state. So on the next slide, you'll see that we do still have some room to improve though. We've been able to reach a lot of patients, some rural patients, and there are still some challenges with broadband access for sure. And we've shown, even with elderly patients, there's been great uptake of digital visits, more than we could have possibly imagined, which is very satisfying. But there are still some vulnerable populations that don't have access to digital health, whether it's a device, it's broadband access, or potentially more importantly, digital literacy. You can give someone a tablet with a cellular data plan, but you have to teach them how to use it. They need familiarity and trust. And we can see, especially in our patients over 65, there are definite disparities in access to patient portals. And without access to a MyChart or a patient portal, you can't do a video visit necessarily or interact with your care team the same way. So we still have a lot of work to do with digital equity, and that will require even more resources to reach those patients and learn the right way with community partners to reach them. So in the last slide, I think I'll share some takeaways. Telehealth in the home is essential to providing patient-centered, value-based care. Rural patients specifically benefit from expanded access to specialty care via digital means, and that patient-physician relationships and continuity of care extend beyond state boundaries. And we really need to enable and provide clarity around these infrequent episodic follow-ups via digital means, because it really is essential providing continuity of care for patients. And then lastly, I would say digital equity is the next social determinant of health, and considerable resources are necessary to prevent worsening of disparities in access to care that we know technology will create. So with that, I'll advance to the last slide and just sort of share a final message that if we're truly serious about the quadruple aim, the quality, the experience, the cost, and the provider wellness as well, expanded access to telehealth and appropriate payment for these services are essential. Thank you very much for the opportunity to share that with you today.
Well, thank you very much. What a great finishing. I love that term, digital equity, Dr. Malinoski. And certainly the AAMC has been very involved in equity and disparities. So this whole issue of digital equity and the role of broadband, which we are also very supportive of, is really important. I thought the two summary slides that both Dr. Rheuban and Dr. Malinoski had were great summary slides. And as we mentioned in the chat, and I mentioned at the beginning, we'll make sure all of you have access to these slides. But, you know, I think the reason why there's been so much discussion at the congressional level and the administration level is, you know, prior to COVID, there really wasn't a lot of policy activity around telehealth. It was related, it was relegated and mostly limited to rural areas because that's where the legislation was, et cetera. And I think, as you've heard from the three presentations today, the real opportunities to improve healthcare generally with adding telehealth to the sort of the toolbox for healthcare and healthcare providers is really important. Obviously, not taking away from the important role of inpatient, but adding to that repertoire has the real opportunity to improve access, actually to reduce costs overall, et cetera. And so you see some of the items here that we are encouraging. These aren't going to be new to any of you. I'm glad that Dr. Malinoski talked about providing telehealth across state lines. It's always a little bit of a complicated issue, but you heard him talk about how important that was for continuity of care. And for many of our large academic medical centers who do treat patients across state lines, whether it's in oncology, cardiology, or in other areas, being able to maintain that continuity of care is really important in that same piece. And we'll come back a little bit to talk about costs and quality, et cetera. Maybe Keith, if you can take down the slide at this point, and we can bring back all of the panelists and open the discussion up for our Q&A. And so we have a couple of questions, but I want to first start by asking, two of the elephants in the room are, what about quality and outcomes, and how ensuring that the right type of visit is being done when it can be done via telehealth, whether versus the person should be in person. I'm wondering if you could talk from your experiences, Dr. Malinoski and Dr. Rheuban, and Dr. Orlowski, if you have any thoughts on that as well. But are you tracking quality and outcomes as you do these telehealth visits?
I'm happy to jump in. So it's important to consider the quality of the technical connection versus the quality of the care. And I think as we launch this rapidly, the existing infrastructures that our academic system had for, let's say, morbidity and mortality conferences or complication conferences or quality assurance, the same infrastructure exists to track complications or challenges that may arise during a digital visit. And that the providers take that on very seriously. And before we began rescheduling patients for digital visits versus in-person ones, each department, each clinic went through their conditions. What type of visit would be appropriate? Which one could be done digitally? Which ones still have to be in person for those 10% or 20% of slots we still keep open, to think about what the right type of care would be. And to be honest, there were still lessons learned, which there would have to be. A patient that you're looking at might not tell you that their legs are really swollen, where if they were in clinic, you would notice that. So the teams have to learn, okay, we need to see our CHF patients at least in person every so often because we might miss things. And so you learn that as you go, and you create registries of complications that occur so you can learn as you move forward. I think clinical teams have the right lens in mind because they're always thinking about that safety and quality and their own comfort providing care. I think that's sometimes the best litmus test.
Couldn't agree more with Dr. Malinoski's analysis. We absolutely incorporate quality assessment in our telemedicine program as well. A truly great example is our telestroke program, where we actually are looking at the outcomes and comparing to in-person services. My teams have demonstrated actually that the time to delivery of telestroke services via obviously telemedicine replicates that of in-person. And another point is the Medicare conditions of participation standards require that we share quality data with our partner facilities, and that's facility-based, but it sets in place the mechanism to evaluate quality in all of the services that we provide.
And I think the only thing that I would add, and Darren, I love what you said, delivery of healthcare and the quality has to be embedded in our usual structures. We can't say we're going to look at quality differently in telehealth or a different standard. This has to be absolutely embedded in the quality and patient safety work that we have at the institutions. as you have demonstrated. And I think the other thing that we are seeing is that professional organizations, the cardiologists, the nephrologists, the pulmonologists, are at their national levels, are taking a look at those conditions that can be appropriately treated by a telehealth and those that they have concerns. And as with everything with medicine, this will be studied and this will be expanded. So I think, though, that the embedding in what is our normal quality and patient safety structures is key.
Terrific. Thanks to all of you on that. I have a quick question that came in, but first, for those of us who are a little bit more laymen than you three physicians who are living in this all the time, I just want to confirm, and correct me if I'm wrong, we use this term e-consults, which is a little bit of a variation of what we're talking about here, right? And e-consult is really electronic consults, and Dr. Malinoski, as we talk about this, we have synchronistic and asynchronistic. The e-consults is really from provider to provider, is the difference. And maybe if the two of you could talk just a little bit about that more, because I think for academic medicine in particular, where so many specialists are, and I think you had such a terrific example, Dr. Malinoski, particularly for rural areas, which I know a lot of our people on the briefing who work in Congress work for members who are in rural areas about how do these e-consults really help ensure and help provide specialty care for some of these more underserved areas, both in rural and in urban areas as well. But I'm just not sure that issue has come out very much. And just wondering if you could elaborate a little bit more about these e-consults.
Certainly, I think you described it pretty well, Karen, that it is an electronic communication between two providers, not with the patient involved directly. And e-consults, actually the first thing I ever got involved in digital health or telehealth, and through the AAMC core collaborative around e-consults. And it really helps create an optimal referral experience, which is what CORE stands for. And e-consults allow for low acuity conditions to continue to be managed by a referring provider, most oftentimes a PCP, who would normally send that patient to a specialist. The specialists have long wait lines at times for patients, access is challenging, and when they see a patient who traveled hours, maybe had to wait months for that visit, and the provider goes, I could have answered this in an email, I feel terrible for this patient, and I could have actually responded, given the referring provider some advice, and they could have continued to manage this care. So what it does is it allows to maintain capacity in specialty clinics for higher acuity patients, to maintain access for those who need it, and you can handle lower acuity conditions in this asynchronous manner in a way that's convenient for both providers, and one's replacing those synchronous phone calls. So someone's calling on the phone waiting for a specialist to answer, they're both waiting, they probably both have patients who are waiting, and that disrupts the care, and it also doesn't have a track record of medical record. So e-consults allow for low acuity conditions to be handled asynchronously, maintain the capacity in the primary care home, upscale those services, and then increase slots for more high acuity patients, and keep the entire conversation in the medical record, and appropriately provide workload credit for services that are provided. So it really checks off a ton of boxes and helps patients get quicker answers to their questions that are needed also.
Dr. Orlowski, I know the AAMC has been working with the Centers for Medicare and Medicaid Innovation, the Center for Medicare and Medicaid Innovation, about this Project CORE. Maybe you could take a moment to talk about that at the national level.
What I would say is that this asynchronous provider-to-provider communications that provides advice, consultation, care recommendations. This is just one of what I see and what we see as the future direction of medicine. Medicine has changed, decade to decade to decade. And what we're involved in right now is just that next expansion in care. Part of it comes about because of the new opportunities with technology, with surveillance, with electronic documentations of, heartbeats and whatnot. But this is how medical care delivery is changing. And I see that CORE is a piece of it. So what you will see is you will see both synchronous and asynchronous care delivery. And this is an example of a way to get really high quality specialty care to anyone, to a primary care physician, to anyone through this consultation methodology. And we have to think then for the future, if this is how medical care is going to be delivered, how do we then modify appropriately the regulations and the payment models so that we continue to be able to provide care in this way?
Great. I have a quick question that came in that says, for Dr. Malinoski and Dr. Rheuban, do you provide, are any telehealth services provided during the non-traditional day, be it, after 5 p.m., before 9 a.m.? How does that work in your systems?
For us, much of what we do is during the regular working hours of our providers. However, we do have, for example, virtual urgent care that we've offered at off hours, and we are scaling that to weekend services as well. Certainly, we have 24/7 services that we have long offered, such as telestroke and some of our emergency telepsychiatry services as well. So most are done during the traditional work hours, but some are 24/7, 365 days a year.
Dr. Malinoski, what about Oregon?
Very similar. Urgent care after hours and weekends, and then telestroke and other programs 24/7. And then recently we started virtual ICU coverage of several hospitals, which is around the clock as well.
Okay. Another question came in a little bit more about the audio, and it's a little bit the inside the beltway question about the cost of how our Congressional Budget Office scores legislation after spending 4.5 years dealing with that when I served on the Hill. We're familiar with that, but is it fair to say as a first opening question that we're supportive at the AAMC, I know all of you are, of enhancing and increasing the broadband access in this country? And so much of the legislation, there's a lot of bipartisan support for that. And, ideally, you'd like to be able to see the person as you talk to them on the phone, but that's just not possible. And we've heard from all of you that in many cases, being able to do a visit via audio is possible, can provide high quality, can make a difference to the patient. And while we would like to have video, the last thing we want to do, though, is to not provide for an option for a patient which would be audio, of which they could receive care that they couldn't otherwise receive now. And I think, Dr. Malinoski, you pointed that out, and I think others have, and we certainly have said that it becomes an equity issue. We're starting to distinguish between patients. And what I would say to the questioner who talks about the CBO score, I think we have to work through that. And I think from our perspective as an association, our focus is to say, what policies do we believe ensure the best care for patients? And right now, having an audio only option must be there until we can get full broadband, as well as a comfort level by patients as well. It's not just broadband. So I think we're going to have to work with the Congressional Budget Office on that front. But from our perspective, what we believe is to say these are policies that we think are going to help patients moving forward, and that's how we look at it. Dr. Orlowski, it looked like you might want to jump in.
You know what? I do believe that this is a care delivery. We are helping patients, but I also think that there's an important system for us to take a look at. And I've had multiple discussions, and that's with Kaiser. Now, Kaiser, although they are involved in Medicaid now, they are a private payer, and they take a look at telehealth. And the senior leaders at Kaiser tell us that 50% of their interactions with their patients are through some telehealth, communication, be it audio only or video and audio. And I think the key will be, if you have someone who has congestive heart failure and they leave the hospital, what you want to do is provide care so that there's not a readmission. Admissions are very expensive. And Kaiser believes, and I think this is the data that we'll need to continue to look at, is that by touching a patient multiple times with telehealth, that what you can actually do is that you can save money. Kaiser believes that. We've talked to them. They have the data within their own system. And the question is can we provide this care, and can we provide this experience, and then can we demonstrate that it is cost effective by either avoiding an admission or avoiding a person getting sicker before they can actually seek care. And that's how I would think about this question. I know the CBO ends up to be something very critical for everyone in Congress to take a look at. But I think that there are definitely studies that demonstrate cost effectiveness in this care delivery.
And Dr. Rheuban, I know you had been looked at the Virginia Medicaid data. I don't know if the experience in Virginia, if you have anything to add to this.
Well, what I would like to add is one of the things that Virginia Medicaid has proposed and other state Medicaid programs have proposed is creation of an audio-only modifier, which will be extremely helpful in evaluating the data that has grown tremendously during the public health emergency in order to inform the CBO in terms of the actual costs and the actual utilization of audio only versus audio video. The other piece that's really important is the prescribing regulations. For example, the DEA requires audio and video to establish a doctor-patient relationship. So, are we talking about audio only in the context of an existing provider-patient relationship, or are we talking about for new patients? So there's a lot of pieces of the puzzle that still need to be put together to make this a more seamless opportunity for our patients.
Dr. Malinoski, would you going to add, please?
Yes, thanks. I would say it's also not just about broadband access for rural patients needing to make sure you have telephone or audio-only coverage, or even patients in metro areas that might lack a device or internet access. There's also patients that have all of that, but just can't do video. We have a neurodegenerative disorder clinic, and the patients have a hard time with dexterity and working through portals and devices and smartphones. And so for them, their only option is in-person or audio. And so there are some patient populations that will need that service. There are even patients who speak different languages who, if your portal and your EHR isn't set up in multiple languages, that they'll have a challenge navigating. But a phone call is something they can do. They can answer a phone, they can dial numbers. And so we have to make sure we're able to reach all patients regardless of their means or abilities.
Okay, thank you. I see we don't have much time left. I'm going to throw a tough one, maybe not a tough one, but something that I think has been asked by a lot of people. Let's just put it on the table. Maybe Dr. Rheuban, if you don't mind starting. And that is the issue around the cost of providing a service. That I think sometimes there's a question that says, shouldn't it be cheaper for healthcare providers if they're doing a telehealth visit versus an in-person visit? And so let's just put that out there. Why isn't it cheaper for you guys to do a telehealth visit versus an in-person visit?
Well, thank you for that question. Certainly, we have spent a great deal of energy, time, money in investing in platforms, in workflows, training, billing and compliance, quality assessment. All of these are expenditures that we have incurred to build and scale our telemedicine program. As I mentioned in my slides, we're actually outsourcing patient support. That's costly for us. And I would say, as a provider myself who does telemedicine, it takes at least the same amount of time to see a patient via video than it does, in person. And we have additional resources we have to apply to that encounter. So I would say parity is important, and even consideration of extending the facility fee, which some of us have been able to collect in relationship to services provided to the home, because it takes significant investments for our healthcare systems to deploy broadly.
Dr. Malinoski or Orlowski, do you want to elaborate, add anything more in our last minute here?
I'll add one data point. Over 75% of all of our IT resources during COVID were committed to digital health, COVID testing, COVID vaccines. So we couldn't do any other IT building during the time because it's such a massive undertaking. We had to hire an additional several, dozens of staff to keep this work going. It does require ongoing support, and clinic staff still room patients. They still have them complete questionnaires. They still have to do primary care maintenance and surveys that are required. So there's still a lot of team members involved, even though it's done virtually.
Dr. Orlowski, we're good?
The only thing that I would say is that in one of my slides, what we saw was American medicine responded to the pandemic in many ways, not just in testing, not just in care of the sick, but we responded within days to weeks. Look at the slide that showed the number of providers going from 200 to 1,000. We responded because we needed to. Now we have to take a step back and take a look at the lessons learned, the care that was delivered, and say, how do we take the lessons from this and incorporate this into the future? And I think telehealth is one of those good stories.
Thanks so much. Thanks to all of you for a really informative presentation. I certainly learned a lot. Keith, my colleague Keith, is putting up our last slide, which has the email addresses that everyone has graciously agreed to do. As we talk about it, Dr. Orlowski and I work at the AAMC and our colleagues, but Dr. Rheuban and Malinoski work at our institutions and do patient care 24/7. I'm proud that my colleague, Dr. Orlowski, still does patient care while also serving as a policy leader for the AAMC. But so appreciative of everyone taking the time out of your day to present. Thank you to all of you who took time out of your day to participate and join us in the briefing. Please feel free to reach out at any time, and on any legislative questions, feel free to reach out to me, and we can have our colleagues in government relations reach out to you. So very informative session. We want to keep it at an hour. Hope everybody has a terrific rest of your day. Thanks so much.